All right, it looks like things have slowed down, so I'll go ahead and get the meeting started today. Good morning, everybody. My name is Melinda Southard, and I serve as the Deputy Director here at the Nevada Health Authority for Community Engagement and Workforce Development. And we appreciate you all joining our public workshop today regarding the statewide healthcare access and recruitment program. We will get into the deck here in a moment, but first I want to call for any public comment. So if anybody has public comment, no action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. Comments will be limited to 3 minutes per person. Persons making public comment will be asked to begin by stating their name for the record and to spell their last name. And you are able to provide written comments as well to the email address noted on the agenda. At this time, is there any public comment? Please feel free to raise your hand if you're using the Teams platform. Yes, Colleen Lawrence.
Good morning. So my name is Colleen Lawrence, for the record, COLEENLAWRENCE. I am with Nevada Pediatric Access Line, and our team at UNLV, we just want to extend our appreciation to the Nevada Health Authority for moving this sharp funding opportunity forward so fast, as we see it as a positive mechanism to improve our access to care and recruitment dilemmas within our behavioral health workforce. And we look forward to more details. Thank you so much.
Excellent. Thank you, Colleen. Is there any other public comment? All right. Seeing none, I'm going to go ahead and dive into the PowerPoint presentation. So we'll go ahead and get things started. I just want to show you the agenda. And just really quickly, a couple of housekeeping items. If you could please be sure to mute your mics if you're not speaking. We will have another opportunity for public comment at the end. And we will also, as you can see as number 4 here, we will have an opportunity for questions and public feedback on the material presented. So appreciate that. Thanks, folks. All right, so today we're going to walk through basically what the SHARP program is, what we're all calling it, the Statewide Healthcare Access and Recruitment Program. Then we'll go into some details on the Nevada Health Authority's plan for the initial assessment and report. And then we'll give a brief overview of kind of the timeline and our next steps and what to expect. And then, as I mentioned, we'll have an opportunity for some questions and public feedback. So diving into the SHARP program itself. Of course, this started with the Nevada 2025 special session with Senate Bill 5 that created this program within the Nevada Health Authority. Just some major elements of the SHARP program through this bill up front. This bill created a new state general fund account, so that's really important because there's a lot of money that was appropriated under this bill. This bill also required a biennial assessment and report. So every 2 years, the Nevada Health Authority is responsible for publishing this required report and submitting it, of course, to the appropriate parties mentioned in the bill. This bill also developed a grant program that is going to be managed by the Nevada Health Authority. The Interim Finance Committee also must approve all of the grants under the SHARP program. So the Nevada Health Authority will have this program and recommend applicants for approval by the Interim Finance Committee. This bill also had an appropriation, a one-time appropriation of $60 million to fund the account. And of that, 3.5% of the money in the account can be used by the Nevada Health Authority for the administrative costs needed to run the program. So let's get into a little bit of the competitive grant program. So there are some requirements to this program, as you'll know if you've read through the bill. So as I mentioned, the Nevada Health Authority will establish and administer this grant program. This program will create awards to very specific entities who are seeking to address shortages of healthcare providers or clinical services or expertise in the state, as well as difficulties in accessing healthcare as identified in the assessment itself. So we're going to see throughout here that we're doing this assessment and the report to inform the request for applications that's going to support the grant program. So it's kind of like an evidence-based grant program, if you will. And basically the overall goal, of course, is to support healthcare workforce capacity and sustainable healthcare here in Nevada. So some of the grant eligibility requirements. So there are specific entities that are eligible to apply for these funds. And it's more specific as those who provide healthcare or coordinate or otherwise facilitate the provision of healthcare. And that can include all the entities listed here. All of these entities are included in the bill itself. As you will notice here, there are some asterisks, and I did provide those additional definitions down at the bottom. Copies of this slide deck will also be available on our website, or actually they're already available on our website, and I will give you all a link to that website here at the end of the presentation. So again, those entities really specific, your medical facilities, community health clinics, the FQHCs, and it goes into different ones like the facilities for treatment of alcohol or other substance use disorders, certified detoxification facilities or programs. And those are very specific, like I mentioned, to those programs that are certified per NRS, as stated here below. Additionally, governmental entities can apply for these funds, as well as nonprofit organizations that provide direct care to patients, training for healthcare providers, or services aimed at expanding access to healthcare, because those are all very important things. Now moving on to the projects. So we talked about those who are eligible to apply. Now let's talk a little bit about the projects that are eligible under this grant funding. So to be eligible for a grant under this program, a proposed project has to be designed to increase the number of healthcare providers, improve the expertise of healthcare providers, or improve access to clinical service or innovative treatments. That's first of all. Then additionally, these projects have to address one or more certified areas of need, and I've defined that in the next slide, so we'll go over that a little bit. And then, of course, these projects have to include specific measurable outcomes to demonstrate, these different data points so we can ensure that there is success in the program, there's sustainability of the program, that it's doing what it's intended to do. Also, these projects have to include a commitment to provide matching funds and in-kind contributions at least equal to the amount of the grant that you're applying for. Also, the project has to demonstrate that sustainability feature that we talked about. You have to have the plans for continued staffing, budget sustainability, continued allocation of resources after the grant ends. So how are you going to sustain this program after the life of the grant? And then, of course, these projects have to demonstrate that either all patient care funded by the grant will be provided in Nevada, or after making a good faith effort to determine a manner in which to satisfy that requirement, the applicant cannot feasibly satisfy that requirement. So you have to provide that additional justification if the patient care funded by the grant will not be provided in Nevada. So for the application itself, like I mentioned, the project has to address the certified area of need. So this means this is an area where a critical shortage of healthcare providers who practice a healthcare profession or specialty, a critical shortage of providers of healthcare in a geographic area of Nevada, or a critical shortage of clinical services or expertise in Nevada or geographic area as identified by the SHARP assessment again, because we're using that as kind of that evidence-based model to inform how we will formulate our grant application. So right now, the Nevada Health Authority is gathering information for this first assessment, and I'm going to let my colleagues talk about that here in a moment. And we are also starting to put together the pieces to develop the competitive request for applications, or RFA, that we will use for the SHARP grant program. The $60 million that was appropriated through SB 5 becomes available after July 1st. So right now there's no funding available. The funding will not be available until after July 1st. And the money that remains in the account, very importantly, does not revert. And it has to be carried forward to the next fiscal year. So that's a really important point, meaning that we can continue to award these grants as long as there's funding in the account. And now just talking a little bit about that administrative piece of the program. So as I mentioned, the Nevada Health Authority can use up to 3.5% of the funds in the account to do these administrative tasks that are associated with carrying on the program. So of course, we're going to utilize those funds to complete the initial assessment. So the bill actually had some very specific language regarding the initial assessment and the allowance for the Nevada Health Authority to utilize existing data sources to create that summary and make the recommendations. We also have to develop a report based upon those assessments. And then develop a complete request for application process. So this is the entire grant program in itself. The application that meets all of the requirements that are specified in Section 11 of the bill. Also, Section 12 of the bill talks about the scoring matrix, or not the scoring matrix itself, but it talks about prioritization of different types of applicants. So that will all be included in the scoring matrix and evaluation process that the Nevada Health Authority will develop. Additionally, we have to, there are specific requirements for the subawards based in Section 14 of the bill. And then, of course, we have to have an ongoing monitoring plan for all subrecipients and ensure that technical assistance, communication, really is a well-oiled machine, for lack of a better term, between the Nevada Health Authority and all of our subrecipients. So it will be a close partnership there. And then additionally, the Nevada Health Authority will be asking for new staff to administer and sustain this program. We're anticipating that request to go to the June IFC, the Interim Finance Committee, for approval. So these staff will, sustain, of course, the RFP or RFA process, apologies, the site visits, subrecipient monitoring, all of the important things that are associated with the operations of this program. And now I'm going to turn it over to my colleagues, Dylan and Maddie, to go over the SHARP assessment and report.
Good morning, everybody. My name is Maddie. I'm the Chief Biostatistician with the Nevada Health Authority. As was just mentioned, we will be doing an assessment for the initial part of this project. If you could go to the next slide, Melinda. So part of the bill requires the Nevada Health Authority to conduct an assessment to include a quantitative analysis of the healthcare workforce in Nevada, a determination of where the critical shortages are in our workforce, and an identification of the unmet needs for specific healthcare technology and therapies. So really the two main questions that we're trying to answer initially are how many providers are practicing in the state, both by region or county, and then by profession or provider type and specialty. And then from that data, where are the greatest needs in our community, both, again, by region, but also by different provider types and specialties in our state. So to do this, on the next slide, we have kind of an overview of what our project is going to look like. So first off, by utilizing claims data, we'll be able to identify what Medicaid is being billed for by providers, both with provider information and what services they're providing. So we can see what level of care is needed in each community, where the people are going to get their services, where those providers are providing services, and the density of providers in specific areas. And then we can use that information to see what does access to healthcare currently look like in each community. And then based off of the data and our findings, we'll be able to really determine what the need is and identify opportunities in each of those areas to improve access to care. So with that, I will hand it over to Dylan to talk about what we know right now.
Thank you. And for those of you who don't know me, I'm Dylan Malmov, and I serve as the Executive Director of the Patient Protection Commission. This section kind of summarizes some of the common themes across existing literature in Nevada, and we're lucky to have a very rich data set from statewide reports and data tools, and you can see some of those linked here on the right of the screen. And they often point to a lot of consistent themes, so much of what I'll highlight today, and especially for this crowd, probably won't be very new. So first, Nevada does not have enough healthcare providers across nearly every major profession, and these shortages are particularly acute in rural and frontier counties where many or all communities are designated as health professional shortage areas, as we'll see a little bit later in the slides. Another theme is that population growth and demand are outpacing workforce supply. Nevada continues to experience strong population growth, especially in Clark and Washoe counties, while workforce gains have been modest once adjusting for that growth. Although the state has expanded training programs and licensure counts have increased across several major professions, Nevada still falls below national per capita averages in many of these areas. And at the same time, nearly half of the physicians are nearing retirement age or over the age of 55, with some of those high need specialties dominated by those older clinicians, which further kind of places limits as the available supply decreases as the population kind of grows. Finally, gaps in behavioral health appear in nearly every report, and as one of the most chronic and persistent shortages. And these themes kind of help provide a comprehensive understanding and baseline context for the SHARP study. Next slide, please. As we move into the data, primary care is one of the areas where these statewide patterns show up most clearly. Nevada's overall physician supply remains well below national averages, and the state would need about 2,300 additional physicians to reach national provider ratios, and a substantial portion of that gap comes from primary care, and we'll see that breakdown a little bit more specifically in the physician table later. But when we're looking at these access indicators, about 65% of Nevadans live in federally designated primary health care professional shortage areas, and 12 of the state's 17 counties are full county shortage areas. This means that primary care shortages aren't just isolated problems. As you can see in this map, they affect both urban and rural communities, though that impact is often felt a little bit more severely in those rural and frontier counties. But together, these data points illustrate why primary care has consistently emerged as a top priority need. Next slide, please. Nevada faces even more severe shortages in mental health providers. About 91% of Nevadans live in federally designated mental health professional shortage areas, and 15 of the state's 17 counties have full county designations. That's 100% of rural and frontier counties. These shortages span the full behavioral health spectrum, including psychiatrists, child and adolescent providers, clinical psychologists, and other behavioral health professions. And those appear consistently across the major workforce reports. And then some of these gaps are reflected in Nevada's persistently low rankings and in national mental health assessments, underscoring kind of both the depth and the longstanding nature of the need in the state. Next slide, please. Dental workforce shortages are another recurring theme. More than half of Nevadans live in designated dental health HPSAs, and 13 of the state's 17 counties are full county shortage areas. These shortages limit access to things like preventative and routine dental care, thinking of things like cleanings, screenings, and early treatment, and those can all lead to downstream health issues when unmet needs escalate into urgent or acute care. When we take these together with the primary care and mental health findings, it continues to kind of show how widespread and multi-sector the challenges are, especially outside of the urban centers of Nevada. Next slide, please. This table shows a subset of Nevada's physician supply and how it compares to national averages, and helps reinforce that the state falls below national per capita levels across most major specialties. Some of those largest gaps include family medicine, where an additional 251 physicians would be needed, pediatrics, where an additional 411 are needed, obstetrics, where an additional 80 are needed, psychiatry, where an additional 105 are needed, and several specialty and hospital-based fields such as oncology, radiology, pathology, and cardiology. Retirement risk further magnifies these shortages. The average physician age in Nevada is 54.8, and 44% of the physician workforce are over the age of 55. And in some high-need specialties, specifically cardiology and obstetrics, older clinicians make up a large share of that workforce. This means when critical gaps may widen as providers retire faster than the state can replace them. And while PAs and APRNs can help extend some of that capacity, the data shows that they also sometimes fall below those national rates as well. Next slide, please. The last slide I want to highlight shows how these shortages extend well beyond physicians and into nursing and allied health professions. So this table just shows a subset of those roles. Nursing shortages are particularly significant. Nevada would need an additional 5,000 RNs to meet national per capita rates, and even larger gaps exist among CNAs, where an additional 5,000 are needed as well, and among home health and personal care aides, where a staggering 23,327 additional are needed. These foundational roles across hospitals, long-term care, home and community-based services, shortages here affect nearly every part of the care continuum. We also see persistent gaps among behavioral health support workforce, including clinical counseling and school psychologists, where an additional 198 are needed, mental health and substance abuse social workers, where an additional 99 are needed, and counselors, where an additional 2,152 are needed. And these mirror the mental health provider gaps we discussed earlier and contribute to that limited access, both in urban and rural areas of the state, and kind of reinforces that Nevada's workforce challenges aren't isolated into any specific area. They span nursing, behavioral health, critical allied health roles, physicians, kind of that whole spectrum that supports access, care coordination, and patient outcomes. And all of this information is kind of what's informing our approach to the study for the SHARP program. I'll hand it back over to Maddie.
So although we have a pretty good base of knowledge, there's still some gaps in what we do and don't know for Nevada specifically. One of the main things is the licensure data does not necessarily reflect active providers. So just because a provider is licensed in Nevada does not necessarily mean that they are practicing. It doesn't include information of where they're practicing, how often, what populations they're serving. So gives us an overview of how many providers there are, but still does not directly address the questions about access to care. This also doesn't relate to specific community needs. So as Dylan was saying, we know we need physicians to meet the national average, but that doesn't necessarily mean that each community has the same need and same demand for services. So we're hoping to be able to see what services people are getting in their communities, where there's gaps, where people are traveling for services, and be able to fill in some of that information. Similarly, that doesn't include telehealth. So for some services, it may be that there's not an active provider in that community, especially in our rural and frontier counties. But there could be access to telehealth that may help fill some of those gaps. Although, as we all know, telehealth does not address all of the needs. So it may help with some services and some level of need in the community, but will, of course, not address all. So trying to identify what that role is and how that is addressing at least some of the need in a community. And then, like I mentioned before, the location of services. So people may be able to access care, but how far do they have to travel? Are people able to get the care that they need in their community? Are people traveling either out of their county or even out of the state to receive services because of lack of access or an increased need within their own community? So that's all information that we are looking into. Like I said, this will be using claims data, which will really be able to give us some of that level of detail that we can hopefully fill in some of this information. And with that, I'll hand it back to Melinda.
Great. Thanks, Maddie. Thanks, Dylan. All right. So now I want to go over just a brief timeline of, what we're looking at for the SHARP program here moving forward. All right, so here we have March right now. As you can tell, the Nevada Health Authority is conducting the assessment to develop the report. So we're looking at all the data sources and, just trying to get to all the information that we can to be able to develop that SHARP report. Then next month in April, we're going to start to compile a draft report of the results of this assessment. And we're also going to start to develop the framework for the RFA for the grant program. Next in May, we'll have another public workshop where we intend to share a draft copy of the actual RFA language and process itself, as well as a draft of the report that will be informing the RFA. So those two things kind of go together. And we'll be requesting public input and feedback on those two items at the May public workshop. Then next in June, we'll plan to publish the SHARP report and we'll, go through all those formalities, and then we will also be sure that that final report, incorporates those elements appropriately into the RFA prior to publishing that RFA. And then July, as you'll remember, the $60 million becomes available starting July 1st. However, we will not have the grant program ready to go come July 1st. So we're hoping to have that RFA available to publish. My goal is by the middle of July. So appreciate you guys just being patient with us as we ensure that we, put that together thoughtfully and mindfully, and that it meets all of the needs of the state, and it's worded in an appropriate manner for folks to be able to apply in compliance with all of the requirements of the bill. So again, looking to release that RFA mid-July of this year. And then I also put a link down at the bottom here because all of the information that we'll be releasing about the SHARP program, including the, the additional public workshop, the information that we'll be posting on our website about the draft materials and all of that will come out through our Nevada Health Authority listserv. So all you have to do is just click that link and send a blank email. I know it feels weird to send a blank email, but that's all you have to do. You don't have to write anything in it, nothing in the subject line, just click and send. Easy peasy. All right, now I want to get into some discussion questions that we have for you all. So with this section, we're kind of looking for your feedback, your input on, how we can do things better. So here, if you just want to use the raise hand feature in Teams to, raise your hand and respond to the question, that works. So we'll start off with question 1. From what we've presented today, is there any gaping holes, any missing available data for healthcare resource supply that we need to be able to review and include in that initial report? So I'll just pause here for a moment if anybody has any thoughts on that. Yeah, Casey.
Hi there, my name is Casey Melvin. I'm the CEO of Tilton's Therapy and Tilton's Therapy for Tots. One of the allied health professionals that I saw that was missing but very critical to lifelong outcomes is speech language pathologists. And I would love to see that information included, as they really help with swallowing disorders. They've played a really big role in adults after intubation and COVID recovery, as well as pediatrics and fostering effective communication across the lifespan. That would be fantastic. Thank you so much for putting this together.
Excellent. Thank you, Casey. Appreciate that. Let's see. Next, I have a comment in the conference room.
Hi, can you hear me okay? This is Constance Young from Safe Hope Cancer Center. I have a question or comment about subspecialized oncologists and nurses. Would be great to see those data as well, as we do provide a lot of subspecialized care and not just the medical oncologist. And in terms of surgical oncologist and then the subspecialized professions under that, it would be great to see too. Thank you.
Great, thank you. Next, I have Max.
Hi, yeah, my name is Dr. Max Koppes. I used to be chair of pediatrics in Reno, and now I'm the head of the cancer center. So I've traveled a lot in North America, and I think as a state we're missing a children's hospital. We're missing a cancer center. And the reason I mention those facilities is because they actually help you also train the next generation. So if you look at the shortage of pediatricians, a children's hospital usually is the ground where you work on that. Cancer centers, the same thing. The previous person made a right comment. It's not only about medical oncologists, although there's a shortage, but I would say that a lot of people leave our state because we're a desert when it comes to cancer care. We don't have, CAR T, BMT, but more importantly, we don't have the infrastructure that helps the state to address these needs. And so we keep recruiting in private practices rather than looking structurally at how can we build the next generation of providers. So I think that that's something that you may want to consider.
Great, thank you, Max. Appreciate that. Next, I have Connor.
Hi, good morning, and thank you for letting me participate. Just to build off of the prior two comments, as far as available data is concerned, I think we should really be making sure that we're considering not only data from a couple of years ago, but even data from the last month or two. So the previous commenter talked about not having a bone marrow transplant or a cellular therapy program. And we actually do now have one in the state of Nevada. So Mountain View Hospital, and I'm with HCA Healthcare, and Mountain View Hospital is part of HCA Healthcare. But Mountain View Hospital started a bone marrow transplant and cellular therapy program roughly a year ago. And we actually completed our 100th bone marrow transplant very recently, which is super exciting. We have two incredible doctors who we recruited from out of the state. They're doing amazing work at Mountain View Hospital with that bone marrow transplant program and cellular therapy program. So some of these resources are in place, and we are just starting to really accelerate what we're able to do. And I want to make sure that as we're looking at data and looking at gaps to address, that we're considering programs like that we literally just brought to the state. In addition to that, I think in the children's space, and I think many are aware, Sunrise Children's Hospital is a 200-bed women's and children's hospital. It has many services that are not offered anywhere else in the state. We recently recruited a pediatric ENT. That ENT started in December, so she has only been there for a few months. We are continuing to expand specialty services and attract new providers and develop new programs. And so I really want to make sure that the data we're looking at is recent data, and that we're considering the things that we're investing in now and getting off the ground, so that this program doesn't, duplicate and potentially undo some of the work that we've already done. I think we need to focus on the existing resources and how we expand upon those resources in our community. Thank you.
Great, thank you for those points. Excellent. We'll just go ahead and move on to the next question. So let's see, we have how should Nevada Health Authority structure the RFA for allocating funds and the number of awards to ensure more than a single awardee? So we're looking at considerations such as, should we have a minimum award amount? Should we have a maximum award amount? How should we consider awarding those applicants? Like, should the Nevada Health Authority have like a definitive timeline for an open application period, such as, 60 or 90 days? And then at that end of that point, the authority takes all those applications, reviews, evaluates, makes awards. And if there's additional funding left over, we can do another application period. Or should it just be first come, first serve and go through it until it's gone? So just want to throw that out there for consideration. Yeah, Dan.
Hey, good morning, Melinda, and thank you, everybody. I worry about a minimum and a maximum. as well as a first come, first serve. I think you really need to have a definitive timeline for the first open application period, and then look at everything you've got and look at exactly what they're asking for. Because you certainly don't want to underfund something that really needs it or overfund, right? So again, I think it's really going to be up to you and the process to open that application, look at everything that comes in, and then like you just said, if at that point you award and have dollars left over, then open up one more application period. I just worry about, again, limiting good projects that may come in, let's say, at the first come, first serve, and someone comes in late, and then there's not enough money for something that really deserves to be funded. So I appreciate the fact that you guys are going to be open and transparent, and I don't worry about the process that you'll go through as long as it's open and fair for everyone.
Yeah, thanks, Dan. Appreciate that. All right, next we have Terry.
Hi, Melinda. It's Terry Chairman of Future Smiles. Thank you for the presentation. I was wondering, will this RFA and the grant process be a reimbursable grant where we spend funds up front and then request an invoice for an RFR after services have been provided and expenses have been paid? And also, can you talk a little bit about the match requirement? Thank you.
Sure, thanks, Terry. Yes, so at the state, our subaward process is a reimbursement based. So entities will need to provide proof of expenditures and then request reimbursement from the state for those expenditures. As for the match requirement, so the bill requires that, there be in-kind match at least 100% of basically what you're requesting for. So, if you're requesting $50,000 in your award, you should have backup to support another $50,000 in in-kind and matching contributions for that. There are some examples in the bill, and I apologize, I don't have those in front of me right now, but we can definitely provide some more technical assistance on that as we develop the RFA. And we can potentially do, like some Q&A and provide more guidance there, and then post that on our website as we're developing the RFA. And even during the open application period, we can also take questions in and provide those answers in a document on our website. Hope that helps. All right, let's see. We do have some questions coming in the chat, so I don't want to ignore those. Apologies, I'm just scrolling. Right.
Do you need me to read those out for you, Melinda?
No, that's okay. Thanks, Monica. I've got one from Marie. Will FNA be allowable? Marie, can you elaborate on FNA and what the impetus of that question is? If you're able to come off mute.
Can you hear me?
Yeah.
Okay, perfect. I work at Orvis here at UNR, and I'm helping with their research and innovation, so I will likely be the one, doing the application and whatnot. So with the university, we have F&A, which is facilities and administration costs, which is usually something part of like federal grants. And I just didn't know if that was something that would be allowable on these applications. If not, a written something from you guys that says we don't allow F&A is all I would need for our sponsored projects department to waive our F&A. But I just kind of wanted to put that out there and see if that was something you guys are thinking about yet.
Thanks, Marie. That's a great point, and I appreciate you bringing that up. So we have not talked about that in detail, but I'm making a note, and we'll talk with leadership about that and see how we want to approach that so that we can, approach that appropriately with the application. So thank you. All right, and I've got another one. Will NVHA be using national standards to determine services Nevadans should be utilizing? My concern with using Medicaid claims is we may not see the unmet needs in claims data. Let's see, Dylan or Maddie, do you guys want to take that one?
Yeah, I can take that one. The answer is yes, that we're planning to use both national data and claims data to kind of supplement each other, understanding that both have their limitations and both may be able to provide a level of detail that the other can't. So yes, we're planning to use the claims data to see like what currently is being used in communities, what services people are getting, but referencing and comparing to national information to determine if there is an unmet need, like you said, that's not, that you can't identify through the claims.
Great, thanks, Maddie. I've got another one from Constance. Will care quality metrics such as 5-year survival rate and patient experience be considered in the initial report? That one, I'm gonna, Maddie or Dylan, do you guys want to take that one also?
Sure, I can take that one. I think some of that, yes, quality metrics can be really difficult with the level of detail that we have in our data, so that would be hard to incorporate. Survival rates, we do have some information that would be able to support that, so I would say yes, we can consider that in our initial report to the level of detail and data that we have available. So we will do our best to include that and kind of consider that, especially in our data findings, but information there can be really limited.
Yeah, thanks, Maddie. Appreciate it. All right, and then I'll just move on to the last question. So, do we have any questions about how this program relates to the Rural Health Transformation Grant Program and GME infrastructure grants? So, before you all ask me about that, I might as well just provide an overview on the Rural Health Transformation Grant Program and the Graduate Medical Education Infrastructure Grants. So basically, the Rural Health Transformation Program is intended to support transformation of how we provide care in our rural areas to increase quality and access of healthcare to rural Nevada. So that is primary on that one. That will be specific to rural Nevada. The rural counties are specifically called out in the guidance from the Centers for Medicaid and Medicare and Medicaid Services, so CMS, in the Notice of Funding Opportunity at the federal level. So we had to follow the designated rural counties per HRSA, the Health Resource Services Administration. And so the counties that are not technically qualified as rural counties are Washoe, Clark, and Carson City. However, those counties are able to collaborate with, partners in rural Nevada to provide healthcare and resources and support to support transformation of healthcare in rural Nevada. So it all goes back to how does it support rural Nevadans in accessing good quality care. With the Graduate Medical Education Infrastructure Grants, the Graduate Medical Education Advisory Council just recently approved, and we have published the request for applications for that grant program. That grant program is specifically aimed at creating or expanding graduate medical education in the state, statewide. And so that is not limited to, the rural areas like the Rural Health Transformation Grant Program is. With the GME grants, there are some additional requirements with that, such as, the accreditation by the, I want to say advisory council, but I think it's the accreditation council for graduate medical education. So the ACGME, you have to be in that process, and if you're creating a new graduate medical education program, you would be in contact with the ACGME. So that, kind of counts, I guess, if you will. And so this program that we're talking about today, the SHARP program, is really intended to support infrastructure developments throughout, so again, statewide, for, to allow Nevadans access to all kinds of care, right? And so we've had a lot of talk today about like different subspecialty care, cancer care deserts, things like that. And so the SHARP program is really intended to help support, better care in Nevada for Nevadans, so they don't have to, go out of state, right, for care, and don't have to travel long distances for care. Because as you know, like our state is huge, and so if you have to travel a lot for care, it really is a huge burden on folks. So I hope that kind of helps, but just want to pause there if there's any questions, comments on that last one. All right, I'm hearing none. So with that, I'm just going to go to the last slide here really quick. So this is all of our contact information. As I had mentioned, we do have a new program website for the SHARP program. So on the slide deck, you can click this link, but I think, will it come up? Oh, it doesn't. Let's see if it will do it for me. There we go. Oh, not found. Not nice. Okay. Apologies, folks. But Monica, I believe, did provide the link in the chat. So you all should have access to that link. And it has all of the information from today's workshop there. And that's where we will be posting all of the information as we move along in this program. We also have a new shared email box. And so that is listed here. And then, of course, our primary web page is noted there. So with that, I'm going to move on to the last item on our agenda, and that is public comment. So again, no action may be taken under a matter raised under public comment unless the matter itself has been specifically included on an agenda as an action item. Comments may be limited to 3 minutes per person. And with that, I will go ahead and call for any public comment. And I see we have the conference room. Go ahead.
Melinda, this is Monica. I don't have public comment, but there was one question that popped back up in the chat. So I wanted to make sure that you saw that.
Oh, thanks.
I wanted to clarify, since K through 12 school-based health settings aren't explicitly listed in the eligibility criteria, would programs that provide or coordinate healthcare services within schools still be considered eligible for this funding opportunity?
That is a great question. I would have to go through the eligibility requirements in the bill, but I really appreciate you raising that. I will make a note and ensure that we do some more research and see if that is a potential eligibility entity. Thank you so much. All right, do we have any other public comment questions? Okay, guys. Well, thank you so much for joining today. Really appreciate your time. I hope you have a great rest of your day. Thanks.
Thanks, Melinda.